Every single day, more than 2,000 Americans die from a heart attack. Not from a sudden, mysterious event, not from bad luck, not from genetics they could not control. They die from something that has been building silently inside their arteries for 20, 30, sometimes 40 years. A slow, quiet construction project happening millimeter by millimeter while they went to work, raised their children, and trusted that their annual checkup would catch anything important. It did not. And here is what almost no cardiologist will say out loud in a 12-minute office visit. In the overwhelming majority of those cases, the heart attack was not caused by the largest, most visible plaque on the scan. It was caused by a smaller, softer, inflamed plaque that nobody was watching, nobody was treating, and nobody even mentioned during the appointment. The patient walked out of that office believing they were fine because their cholesterol number looked acceptable. 3 months later, their family was making funeral arrangements. That is not an exaggeration. That is the standard pattern documented in cardiology literature for the last 2 decades. Now, before going any further, this channel exists for one reason: to give people over 50 the information that the system either does not have time to share or does not financially benefit from sharing. Subscribe to Dr. Waterling right now and hit the like button. The goal is to reach 1,000 subscribers, and the channel is being built on one principle. The system makes money when patients stay sick, not when they get better. Every person who subscribes helps push real information into the feeds of people who desperately need it. Now let me be direct. Arterial plaque is not a permanent sentence. It is not a one-way road. It is a dynamic, living process that responds to specific inputs every single day. The body is constantly building plaque and constantly clearing it. The only question is which process is winning. And in 15 years of clinical practice, working with patients ranging in age from 45 to 88, the conclusion has become impossible to ignore. The patients who reverse plaque are not the ones with the best genetics or the most expensive supplements. They are the ones who understand the mechanism and apply 3 simple daily interventions with discipline. That is what this video will give: the mechanism, the interventions, and the exact protocol. But first, the truth about what plaque actually is, because almost everything most people believe about it is wrong. Most people picture arterial plaque as something like grease building up inside a kitchen pipe. A layer of fat slowly thickening the wall, narrowing the channel, eventually blocking the flow. That image is comforting because it suggests a simple solution: stop eating fat and the pipe stays clean. That image is wrong. And the misunderstanding has cost millions of lives. Atherosclerotic plaque does not begin with fat sitting on the surface of the artery wall. It begins inside the wall itself. The inner lining of every artery is covered by a delicate single-cell layer called the endothelium. Think of it as the body's most important non-stick coating. When that coating is intact and healthy, nothing sticks to it. Cholesterol flows past it. Inflammatory cells flow past it. Calcium flows past it. Nothing accumulates. The problem begins when the endothelium gets damaged. And here is what damages it: not dietary fat, not eggs, not red meat in moderate amounts. The actual damage comes from chronic high blood sugar, oxidized seed oils consumed in industrial quantities, persistent low-grade inflammation from poor sleep and chronic stress, elevated blood pressure that physically batters the artery wall, and excess insulin circulating constantly because of frequent eating and refined carbohydrate consumption. Once the endothelium develops a microscopic crack, the body does exactly what it is designed to do. It tries to patch it. Small particles of LDL cholesterol slip into the crack. White blood cells called macrophages follow them in to clean up the mess, and these macrophages become engorged with oxidized cholesterol and turn into what pathologists call foam cells. Layer upon layer of these foam cells, combined with calcium deposits the body uses to reinforce the patch, build up over years into a structure called a plaque. This is the most important sentence in this entire video. Cholesterol is not the cause of plaque. Cholesterol is the body's repair material responding to a wound that someone else inflicted on the artery wall. That distinction changes everything. Because if cholesterol is the repair crew, then lowering cholesterol while continuing to damage the artery is like firing the firefighters while the building keeps burning. The fire does not go out. It just burns without anyone trying to stop it. Now, the pancreas of cardiovascular medicine, the part that nobody wants to discuss, is the distinction between stable and unstable plaque. A stable plaque has a thick, fibrous cap covering it. It is calcified, hard, and while it may narrow the artery, it rarely ruptures. An unstable plaque has a thin cap, is full of soft, inflammatory material, and can rupture without warning. When it ruptures, the contents spill into the bloodstream. The body forms an emergency clot to seal it, and that clot blocks the artery completely. That is a heart attack. The standard cardiology workup measures total plaque burden. It does not reliably distinguish stable from unstable. which means the patient with one large stable plaque may be safer than the patient with three small unstable ones. And the interventions that stabilize plaque, that turn the dangerous soft variety into the safer hard variety, are almost entirely nutritional and behavioral. They are not pharmaceutical. That is why this matters. That is why the conventional approach fails so many people. Walk into any cardiologist's office in America with mildly elevated cholesterol and the protocol is remarkably consistent. A statin prescription, a vague recommendation to eat less fat and exercise more, a follow-up appointment in 6 months to recheck the lipid panel. If the LDL number drops, the visit is considered a success. The patient leaves believing the problem is solved. That patient has been failed, not because the statin is necessarily wrong, though for many patients it is prescribed unnecessarily, but because nothing in that visit addressed the actual cause of the endothelial damage. The patient is still eating the same processed foods, still sleeping poorly, still carrying the same visceral fat around the midsection, still consuming the same industrial seed oils in restaurant cooking. The fire is still burning. The cholesterol number on paper looks better. The arteries underneath continue to deteriorate. This is not a conspiracy theory. This is what cardiology literature openly admits. Studies have repeatedly shown that 50% of heart attack patients had so-called normal cholesterol levels at the time of the event. 50%. Half of all heart attacks happen in people the conventional model says are not at significant risk. There is no billing code for teaching a patient how to actually eat. There is no reimbursement for spending 45 minutes explaining the difference between visceral and subcutaneous fat. There is no insurance coverage for the nutritional education that would actually prevent the disease. The 12-minute office visit, the prescription pad, and the follow-up labs represent what the system pays for. Anything beyond that comes out of the physician's own time, and most physicians simply do not have it. So patients try other things. They buy fish oil supplements based on a television advertisement. They switch to margarine because someone told them butter is dangerous. They start drinking apple cider vinegar every morning. They take garlic capsules. They try every trending supplement that promises arterial cleansing. And the plaque continues to grow because none of these interventions address the root cause. Now here is what actually works. And this is where the real value of this video begins, so stay with this section carefully. 3 interventions supported by published research and consistent clinical observation can measurably reduce plaque burden and stabilize the dangerous soft plaques within 90 to 180 days. They cost almost nothing. They require no prescription. They use ingredients available at any grocery store. The first intervention is the morning artery protocol drink. This is a specific combination of ingredients that addresses 3 mechanisms simultaneously. It reduces post-meal blood sugar spikes that damage the endothelium, supplies nitric oxide precursors that help the artery walls relax and heal, and provides soluble fiber that binds excess cholesterol in the digestive tract before it can be reabsorbed. Here is the exact recipe. Take 1 tablespoon, approximately 10 grams, of whole flax seeds and grind them in a coffee grinder or blender immediately before use. Ground flax seeds oxidize quickly, so pre-ground flax loses its protective compounds within days. Add the freshly ground flax to 250 milliliters, about 1 cup of warm water. Not hot, not boiling, just warm to the touch, around 40 degrees Celsius or 104 degrees Fahrenheit. Add 1 teaspoon of raw, unfiltered apple cider vinegar, with the mother visible at the bottom of the bottle. Add a small pinch, less than 1/4 teaspoon, of pure cayenne pepper. Stir thoroughly and drink within 3 minutes before the flax begins to thicken into a gel. Consume this 20 to 30 minutes before breakfast every single morning without exception. The flax provides lignans and soluble fiber. The vinegar improves insulin sensitivity for the meal that follows. The cayenne provides capsaicin, which has been shown in published research to improve endothelial function and circulation. The second intervention is the daily nitric oxide builder. The arteries produce a molecule called nitric oxide that signals the smooth muscle in the artery wall to relax. When nitric oxide production declines, which happens naturally with age and accelerates dramatically with poor diet, the arteries become stiff and unable to dilate properly. Restoring nitric oxide production directly improves blood pressure and reduces ongoing endothelial stress. The richest dietary source of nitric oxide precursors is not what most people assume. It is not beets in supplement form. It is dark leafy greens consumed daily in adequate quantity. Specifically, 2 cups of raw arugula, spinach, or Swiss chard, eaten with a meal containing healthy fat, will provide approximately 400 to 800 milligrams of dietary nitrates. The fat is important because it slows absorption and allows the conversion to nitric oxide to occur properly in the mouth and stomach. Here is the exact protocol. With lunch every day, prepare a salad containing 2 cups of mixed dark leafy greens, half an avocado sliced thin, 1 tablespoon of cold-pressed extra virgin olive oil, the juice of half a lemon, and a small pinch of sea salt. Eat this salad before the main portion of the meal, chewing thoroughly. The thorough chewing matters because oral bacteria perform the first step of nitrate conversion. Rinsing with antibacterial mouthwash within 2 hours of this meal will undo most of the benefit, so avoid mouthwash near these meals. The third intervention is the evening anti-inflammatory protocol. Chronic inflammation is the engine that drives plaque instability. Reducing systemic inflammation in a measurable way requires consistent intake of specific compounds. The most well-researched of these are the polyphenols found in concentrated form in certain spices and foods. Here's the evening drink. Heat 250 milliliters, 1 cup of unsweetened almond milk or whole organic cow's milk in a small saucepan over low heat. Do not boil. When the milk is warm to the touch, add 1/2 teaspoon of pure ground turmeric, 1/4 teaspoon of ground ginger, 2 or 3 generous pinches of freshly ground black pepper, and 1/2 teaspoon of raw honey or pure maple syrup if desired. The black pepper is not optional. It contains piperine, which increases turmeric absorption by approximately 2,000%. Without the pepper, the turmeric passes through the body largely unused. Drink this 60 to 90 minutes before bed. The combination provides curcumin, which has been documented in multiple meta-analyses to reduce inflammatory markers including C-reactive protein, the same marker cardiologists measure to assess cardiovascular risk. Now, how old are you right now? Write it in the comments below. The age distribution of the people watching this video directly shapes which topics get covered next, and the most engaged age groups receive the most targeted content. So drop your age in the comments, even if it is just the number. Subscribe to Dr. Waterling if this information is making sense. The goal remains 1,000 subscribers, and every single subscriber pushes this content into the feeds of more people who need to hear it before they have an event that could have been prevented. Now consider Margaret, age 67. She came in 2 years ago after her cardiologist recommended a stent procedure based on a CT angiogram showing 60% blockage in her left anterior descending artery, the vessel cardiologists call the widowmaker. She had been on a statin for 8 years. Her LDL cholesterol was 78, well within the acceptable range. Her blood pressure was controlled with medication. By every standard metric, she was being managed appropriately, and her arteries were continuing to deteriorate. Her presenting symptoms were mild fatigue with walking, occasional pressure in her chest with stairs, and a vague sense that something was wrong that she could not articulate. She had tried fish oil supplements, garlic capsules, a low-fat diet that left her constantly hungry, and a gym membership she used inconsistently because the exertion made her feel worse. The diagnostic revelation came from looking at the right markers. Her C-reactive protein was elevated at 4.2 milligrams per liter, indicating significant chronic inflammation. Her fasting insulin was 18 micro-international units per milliliter, indicating early insulin resistance her cardiologist had never measured. Her HDL was low at 41. Her triglycerides were elevated at 168. The standard cholesterol panel had been reassuring while every meaningful marker of actual cardiovascular risk was screaming. The intervention was the 3-part protocol described in this video combined with a complete change in eating pattern. She eliminated all industrial seed oils, all refined flour products, all sugar except small amounts of fruit, and shifted her eating window to between 11 in the morning and 7 in the evening. She walked 30 minutes daily, not as exercise, simply as movement, after her largest meal. 6 months later, her repeat CT angiogram showed the plaque had reduced from 60% to 47% stenosis. Her C-reactive protein dropped to 0.8. Her fasting insulin dropped to 7. Her HDL rose to 58. Her symptoms had completely resolved. The stent procedure was canceled. She has not needed it since. That is what is possible when the actual mechanism is addressed. That is what conventional management almost never delivers because the protocol is not in the standard guidelines. Now, the practical section, the complete daily implementation, organized so there is no ambiguity about what to do and when. Morning, immediately upon waking. Do not check the phone. Drink 500 milliliters, about 16 ounces of room temperature water with a pinch of unrefined sea salt. This rehydrates the blood, which has thickened overnight, and reduces the morning blood pressure spike that causes most heart attacks to occur between 4 and 10 in the morning. 20 to 30 minutes later, prepare and drink the flax protocol drink described earlier. Wait another 20 minutes before eating breakfast. Breakfast should contain real protein and healthy fat. 3 eggs cooked in butter, half an avocado, and a handful of berries is ideal. Skip the cereal, the toast, the orange juice, and the oatmeal with sugar. Those foods spike insulin and undo the morning's preparation. Mid-morning, move the body. 20 minutes of walking outside if possible. Sunlight on the skin in the morning hours is genuinely cardioprotective through mechanisms involving nitric oxide release and circadian regulation. This is not optional. It is one of the most underrated cardiovascular interventions available. Lunch. The dark leafy green salad protocol described earlier, eaten before the main portion of the meal. The main portion should consist of approximately 4 to 6 ounces of clean protein, fish, chicken, or grass-fed beef, and a generous serving of cooked vegetables prepared in butter, olive oil, or coconut oil. No vegetable oils, no canola, no soybean oil, no corn oil. These are the primary industrial sources of arterial damage in the modern diet. Afternoon? Continue drinking water consistently. A glass every hour. Dehydration thickens the blood and increases workload on the heart silently throughout the day. Dinner. Eat the largest meal of the day at least 3 hours before sleep. Late eating elevates overnight insulin, disrupts sleep quality, and accelerates plaque formation. A meal eaten at 6 in the evening protects the arteries. The same meal eaten at 9 in the evening damages them. Evening, 60 to 90 minutes before bed. The turmeric anti-inflammatory drink described earlier, followed by 10 minutes of slow nasal breathing. Specifically, inhale through the nose for a count of 4, hold for a count of 4, exhale through the nose for a count of 6, hold empty for a count of 2. Repeat for 10 minutes. This activates the parasympathetic nervous system, lowers nighttime blood pressure, and improves sleep quality, which is when the body performs most of its arterial repair work. Sleep. Aim for 7 to 8 hours in a completely dark, cool room. Sleep is when the arteries heal. A patient who sleeps 5 hours per night cannot reverse plaque, no matter how perfect the diet, because the repair processes do not run without adequate sleep time. The expected timeline for results. Within the first 2 weeks, energy improves, and any chest tightness with exertion typically reduces noticeably. Within 4 to 6 weeks, blood pressure measurements drop measurably, often by 10 to 20 points systolic. By 90 days, inflammatory markers including C-reactive protein typically reduce by half or more. Between 90 and 180 days, repeat imaging in patients who have followed the protocol consistently has shown measurable plaque regression in the range of 5 to 15%. Continued for 2 to 3 years, the regression can exceed 30% in committed patients. Now, the critical safety information. There are symptoms that should send a person straight to an emergency room, not to a video. Crushing chest pain or pressure lasting more than a few minutes. Pain radiating to the jaw, the left arm, or between the shoulder blades. Sudden severe shortness of breath at rest. Cold sweats with nausea and a sense of impending doom. Sudden severe weakness on one side of the body, drooping face, or difficulty speaking. Any of these symptoms requires calling emergency services immediately. Do not drive. Do not wait. Do not finish the morning routine. These are signs of an active cardiovascular event, and minutes determine whether the heart muscle survives. If currently taking a statin, a blood pressure medication, a blood thinner like warfarin or apixaban, or any cardiac medication, do not discontinue or modify the dose based on anything in this video. The nutritional interventions described here work alongside medication, not as a replacement. As the diet improves, blood pressure may drop, blood sugar may improve, and inflammation markers may decline. The prescribing physician needs to monitor those changes and adjust medications accordingly. This is collaboration with medicine, not rebellion against it. For those with a history of bleeding disorders, kidney disease, or active gallbladder disease, some of these interventions require modification. Flax seeds are not appropriate for people with bowel obstruction or active diverticulitis flare. Turmeric in concentrated form may interact with blood thinners. Apple cider vinegar may worsen reflux in sensitive individuals. The general protocol applies to functional cardiovascular concerns in otherwise healthy adults. Complex cardiac patients need individualized guidance from a physician who understands both pharmaceutical and nutritional medicine. The body is not broken. The arteries are not the enemy. The plaque that has built up over decades did not appear randomly, and it does not have to be permanent. Every meal is either contributing to arterial damage or contributing to arterial repair. Every night of sleep is either allowing the repair processes to run or interrupting them. Every day the body either receives the raw materials it needs to heal the endothelium or it does not. The healthcare system is not built to deliver this information. The 12-minute office visit cannot accommodate it. The pharmaceutical model does not benefit from it. That is not a moral failing of any individual physician. It is the structure of the system. The information has to come from somewhere else, which is why this channel exists and why the work of building it to 1,000 subscribers matters. Subscribe to Dr. Waterling if this video has changed how cardiovascular health makes sense. Hit the like button if a specific point landed. Drop the age in the comments because that information directly shapes future content. And if this video helped, send it to someone who matters. A parent, a sibling, a friend who has been told their cholesterol is borderline and given a vague recommendation to eat less fat. Send it to the person who came home from their last cardiology appointment confused and uncertain. They may not know it yet, but a 25-minute video could be the difference between an event they did not see coming and the years of life they did not know were still available to them. The arteries can heal. The plaque can regress. The body is waiting for the inputs that allow it to do what it has always known how to do. Give it those inputs, consistently, every single day, starting tomorrow morning with the first glass of water. The next 90 days can change everything.